are good to go, sir.
We're starting. Thank you.
Well, hello everybody. Thank you for the invitation to be here. I'm going to talk to you today about management of pleural effusion. I would say malignant pleural effusion. Kind of slowing down on the speed that was already with the previous talk. It was very good actually. But I have nothing to disclose. Today we're going to talk about introduction first, see some generalities about malignant pleural effusion, but mainly we're going to focus on the management. What are the options that we have? Different options, and then we'll jump to conclusions. Malignant pleural effusion is a very common condition. The incidence in the United States is around 175,000 in the country. It's very commonly seen in patients who already died with cancer, 15%. 1/3 of patients with lung cancer will have at some point during the course of the disease malignant effusion. More than 50% of patients who presented with exudative effusions are actually malignant. Malignant effusions constitute the third most common cause of effusions in general, which is after heart failure, which is usually transudative, and then parapneumonic effusion as a second place. And malignant effusions are actually the most common cause of lymphocytic effusion. So remember, this is what we always discuss when the fellows rotate in bronchoscopy suite, is when we manage any patient with pleural effusions in general, what we look for is exudative effusions that are actually lymphocytic predominant. The two most common causes of malignant effusions are actually lung and breast cancer as primary. They actually constitute more than 50% of all the causes of effusion, followed by lymphoma. How do cancer cells or malignant cells get actually to the pleural fluid? There are different mechanisms, and depending also on the type of cancer, they can actually travel or spread through the lymph nodes or lymphatic spread in general, like it's seen actually in lung or breast cancer. They can actually get there through a hematogenous spread. When there is lymphatic obstruction, for example in lymphoma, in Hodgkin's lymphoma, there could be a direct invasion of the pleura by the tumor itself. It says no Hodgkin's lymphoma, but you can see that also in lung cancer patients. Now, if there is invasion of the blood vessels, what we see typically is a hemorrhagic malignant effusion. It is important to mention that not every single patient who has cancer has an effusion is actually a malignant effusion. There's an entity called a paramalignant effusion, which is also important to know, and the reason for that is prognosis. The mechanism of a formation of a paramalignant effusion is usually due to an obstruction of the thoracic duct, for example, that is seen, let's say, in lymphoma. What it does, it decreases the drainage of the pleural fluid, for which the patients will develop effusion, but it's a non-malignant effusion. Bronchial obstruction with formation of atelectasis. Remember, if there's an atelectasis of part of the lung or the entire lung, there will be a formation of fluid or accumulation of pleural fluid that is not necessarily malignant. Patients with trapped lung will present the same way. If the patient is actually receiving chemotherapy, agents like bleomycin, cyclophosphamide, methotrexate, or even radiation can present also with pleural effusion without being malignant. Patients with post-obstructive pneumonia and pulmonary embolism are other causes of pleural effusion, called also paramalignant effusion in patients with cancer. Why is that important? Prognosis. In general, we know that prognosis of malignant effusion is poor. This study actually in 85 patients with malignant effusion, tried to find out what were the predictive factors for survival in this kind of patients. They use what we probably all know, which is the Karnofsky performance score. This score goes from 0 to 100, and you can see a patient with 100 score means that it has a normal performance with no complaints and no evidence of disease, whereas patients with a score of 0 is a dead patient. They actually found, and this is important, look at this, that patients with the highest Karnofsky score of 70 or above 70 and malignant effusion with cancer, of course, the median survival was a little bit more than 1 year. So you're talking about the best patient in terms of performance status who presents with malignant effusion at some point during the course. They will not live a little bit more than a year. So you have to keep that in mind. Of course, if the Karnofsky score is less than 30, the survival or the median survival is only a month. Important to mention. Other predictor factors that they actually measure in this study was low glucose and high risk tumors, but the one that actually predicted better was the Karnofsky score. So what is really the goal of management? Knowing these facts already, poor survival in this kind of patients. Do we try to really improve the survival in these patients? No, because the cancer will take over that. So the goal in the management of malignant effusion is not to improve survival at all. 90% of these patients will have some degree of dyspnea. And that's exactly where the goal of management should be directed to. Management and palliation of dyspnea. What are the management options that we have when it comes to malignant effusions? Well, there's different varieties. Observation. We just observe that the patient has an effusion. If the patient is asymptomatic, probably doesn't need anything, since the goal of care is actually at that moment just to relieve dyspnea. Then the patient is not dyspneic, does not need anything. Repeated thoracentesis, therapeutic thoracentesis. Pleurodesis that can actually be done either through a chest tube or it can be done through a thoracoscopic procedure. And then the management with indwelling or the placement of indwelling pleural catheters that we are all familiar with. So let's go one by one. Observation. As I said before, 90% of patients will present with dyspnea who have malignant effusions. Others will present with cough or chest discomfort. The dyspnea pretty much come, as you see in the ultrasound images here, because of the pressure of the fluid that is actually putting against the diaphragm. Sometimes the pressure could be such that the diaphragm gets inverted. When that happens, there is less generation of negative pressure during inspiration, which will actually activate the dyspnea sensors that are actually in the chest, which will create the sensation of dyspnea. However, if the patients do not have dyspnea, they're asymptomatic, despite having a pleural effusion, then really observation would be the right thing to do. You don't need to do any other procedure at all. And observant, it is hard to say at this point because the problem is you know that there will be recurrence of effusion. Most of them recur after a month, almost in 100% of the times. So observation of them and good relationship with the patients in terms of telling or letting you know when the dyspnea recurs would be the right, the way to go in these kind of patients. Repeated thoracentesis. Again, the advantage of repeated thoracentesis, a thoracentesis or a therapeutic thoracentesis will cause an immediate relief of dyspnea, and we all know that. What is the problem? There's actually, as I mentioned already, high recurrence rate. Almost 100% of the patients will have a recurrent malignant effusion in a period of a month. Now, With repeated thoracentesis, one of the issues could be that there is more formation of adhesions long term, which can limit or may limit future interventions, thoracoscopic interventions, like, for example, pleurodesis. It is important to mention that there are actually cancers that are very sensitive to chemotherapy, and even though they may present with malignant pleural effusions, since they are very sensitive, they respond very well to chemotherapy, like lymphoma, small cell cancer, or breast cancer. So knowing that, maybe observation or just repeated thoracentesis would be the right thing to do in these kind of patients until chemotherapy starts doing the effect that we want. Also, it's important to mention what pneumothorax ex-vacuo is. We're all familiar with this, also called trap lung. What it means is there has been some thickening of the pleural, the visceral pleura, that does not allow the lung to re-expand. Usually this is due to cancer spread. Most of these patients will have actually a lung parenchymal disease also. When you perform thoracentesis in these kind of patients and drain the fluid, most of these patients will actually have some degree of pain while draining. And if you do a chest X-ray, you will find air in the pleural space, not necessarily a pneumothorax caused by your procedure itself, but probably you drain too much. What happens with these patients is the recurrence of pleural effusion is actually much faster than just a month. We're talking about after 3 or 5 days, the pleural fluid will return. So it is. Yes, you do improve the dyspnea in these kind of patients. However, after less than a week, they reaccumulate again so fast that patients probably will be better served with a more definitive procedure for this, or therapy. What is the other option? Pleurodesis. Pleurodesis is a procedure that involves the instillation of an agent or esclerosant agent into the pleural space. There are different esclerosant agents in general, but what it tries to do is it creates a degree of inflammations that will actually cause a release of different cytokines and all inflammatory response in the visceral pleura as well as the parietal pleura. That response and that inflammation will create an approach between those two membranes, and eventually what we call a pleurodesis of the space, reducing the interpleural space to the minimum. So pleurodesis, the indication, so when do we do pleurodesis? If the patient has a survival, or the patient has to have a survival at least of more than 1 or 3 months. If you think that the patient is not going to survive that long, probably repeated thoracentesis will be the way to go. And the reason for that is pleurodesis is a much more complex procedure. It involves sometimes hospitalization of the patient. It involves a lot of resources and is very expensive. So if the survival rate is more than 1 or 3 months, then you may consider pleurodesis as an alternative. Now, you must have an almost complete expansion of the lung after draining the pleural fluid in order for the pleurodesis to be effective. If you have a pneumothorax post-vacuo or ex-vacuo, as I mentioned before, or the patient has a trap lung when there is no apposition of both pleural membranes, probably the pleurodesis will fail. There are different esclerosing agents that have been already studied in multiple trials, and we're going to go over them in a minute. The most common one and the most effective one so far has been talc. Now, pleurodesis, as I mentioned earlier, can actually be performed through a chest tube, or it can be performed through a thoracoscopic procedure, thoracoscopy or VATS, medical thoracoscopy, pleuroscopy, etc. Now, when it comes to chest tube pleurodesis, actually this procedure can be done or has been shown to be done as an inpatient, but also outpatients can have this procedure done. I'll show you a study in a few more minutes. And this is what I meant by trap lung. This patient has a trap lung. You can see that the visceral pleura is thickened. There is no opposition between the visceral pleura and the parietal pleura, for which pleurodesis, this is not a candidate for pleurodesis. Pleurodesis will fail if we attempt to do that in this patient. Going over different agents for pleurodesis, this is actually a nice diagram. You can see the ones that have been studied the most actually have been the use of talc. There are two different types of talc presentations that are actually used in patients for pleurodesis. One is the slurry talc, or talc slurry, which is pretty much talc mixed with normal saline. The amount will vary depending on the study. It goes from 50 to 100, sometimes can go to 250 milliliters of saline. And that's actually slurred through the chest tube most of the times. The other presentation is the talc poudrage, which can only be used through a thoracoscopic procedure. You cannot put some powder or talc powder through the chest tube. It's impossible. Now, the success rate, as you can see, is actually pretty high with talc in different studies compared to the other agents. The complications have actually, most of the time, involved chest pain, fever, but also you can see complications as ARDS or pneumonitis. This actually has come down a lot since they started to use graded talc. Before, it was a non-graded talc, which means that the particles of talc that they were used or they were found on that samples were actually less than 5 microns. But now, as a graded talc, the particles should not go below 15 microns. What the belief was that because the particles were so small, they would just go through the visceral membrane and create this pneumonitis or inflammation of the lung in general, leading to ARDS. That's not being seen anymore. So talc pleurodesis, this is actually a study that was done to try to compare talc poudrage versus talc slur. This was in 100 patients. It was non-randomized. But the reason why I wanted to show you is to see in both types of talc, the chest pain and fever were the most common complications. The same study also showed that a better effectiveness of talc poudrage compared to talc slur after 30 and 90 days. As I said, this was a non-randomized study. When they did this randomized study in 500 patients, actually showed that the efficacy was pretty much similar in both. Chest tube pleurodesis. Different types of techniques have been described in different studies. Every study that you see, you'll find a different technique. This actually was a nice study done with a survey to more than 800 physicians, pulmonologists mainly, who would perform pleurodesis. This survey was taken in pulmonologists from United States, Canada, UK, Australia, and New Zealand. So what they did was ask questions about what technique would you use, and be more specific in terms of the questions. So, when would you do pleurodesis? Would you do it after you find for the first time malignant effusion, knowing that it's going to recur? Would you do it after the first recurrence? Would you do it after the second recurrence? Most of them, at least after one recurrence of the malignant effusion. Now, would you use chest tubes, a large bore chest tube versus a small chest tube? Actually, they found that most of them will use a small bore chest tube, 10 to 14 French, pigtail catheters, etc. They would do the same effect, or they didn't see any changes in the effectiveness, but they did see changes in terms of pain. Patients with small bore chest tubes would have less pain compared to the large chest tubes, and we already know that from other studies done for different reasons. A sclerosant agent that is actually would be used more commonly in the study was talc. And they actually, they perform, most of them did perform ultrasound to show apposition after they drain the entire fluid. They actually would clamp, and I didn't put it here, but they would clamp the chest tube for 1 hour, and then some of the pulmonologists will rotate the patients to try to spread all this slurred talc into the pleural space. However, most of the pulmonologists didn't feel that that would make a big difference in terms of effectiveness of pleurodesis. Many of them would avoid the steroids. They did use, though, lidocaine instillation right before they instilled the sclerosant agent. And the success rate in general, what they saw was a range between 60 and 80%. Now, pleurodesis has also been performed in the outpatient setting. This is actually just a case series of 10 patients with cancer in which they placed a chest tube, a 14 French chest tube, pigtail catheter attached to a drainage system. They discharged the patient home after the placement of the chest tube. They would drain it every day, and until the drainage was less than 100 milliliters, then the patients would return to the hospital at that time. At that time, they would perform the pleurodesis with talc slurry. They leave the chest tube for an hour clamped. Patients go home, and then the next day the patients return for removal of the chest tube. So it can be done. And if you see, the mean duration of the chest tube being in position was 6 days. Now, there has not been any study, any other study that has addressed this with a big quantity of patients. This is, as I said, was just a case series. Now, the main meta-analysis that we all talk about when it comes to pleurodesis, it was actually done by Shaw and Agarwal from the UK. It involved 36 randomized controlled trials. This is only for pleurodesis and malignant pleural effusion. Almost 1,500 participants or patients in general. They used different kind of sclerosing agents. At that time, one of the questions was, could the use of chest tube alone versus chest tube plus sclerosing agent be different? And yes, sclerosing agents in general increase the efficacy of pleurodesis versus chest tube alone. I mean, we all knew that at the time, but they wanted to answer that question. Now, out of all the sclerosing agents that were used, the one with the highest efficacy was actually talc. And there was no big difference between talc slurry versus talc poudrage. In general, thoracoscopic pleurodesis was more effective than chest tube pleurodesis with all the sclerosing agents. So effectiveness comes, thoracoscopic pleurodesis is better in terms of effectiveness, but we're going to talk about that in a few more minutes with another kind of slide. So, thoracoscopy or thoracoscopic procedure we're all familiar with. It can actually be diagnostic or therapeutic. You can perform talc pleurodesis through thoracoscopy, and you can do it medical, or there are two different types of thoracoscopy, medical or surgical. This is just to show a graphic of the pleura there with a big tumor. Once you get into the pleural space, you see the tumor, you know this is already malignant effusion. Even if you didn't make the diagnosis, you made the diagnosis right there. You send it for frozen, and you can go ahead and proceed with your therapeutic option, which would be probably pleurodesis, if you decided to do that. Some differences between medical and surgical thoracoscopy. I think the main difference is the use of conscious sedation in medical thoracoscopy, also called pleuroscopy. We perform that procedure in the OR. However, we don't use general anesthesia at all. We just use conscious sedation. compared to the surgical thoracoscopy, which is general anesthesia. Surgical thoracoscopy requires intubation of the patients to try to deflate the lung of the side they're going to work on. We don't do that. We do not need that. However, we do need fluid. Otherwise, when you put a trocar, you have a high risk of perforating the lung. You don't want that. So you need the fluid as a cushion in between the chest wall and the lung. You can go with 1 or 2 trocars. We can do it. They actually can go probably with more than that if they want to. One of the disadvantages is that we can do lysis of simple adhesions. However, if the patient does have a trapped lung, for example, with thickening of the visceral pleura, probably they will need decortication, and that can be done only through a surgical thoracoscopy, not us. It's just too much for us. We just go with simple things. In terms of mortality, you can see the mortality is actually is worse with surgical thoracoscopy, but of course their cases definitely are much more complex than the cases that we take for these kind of procedures. The complications are very similar. The diagnostic yield for malignancy is similar. We take biopsies from the same places, and the efficacy of pleurodesis is also similar too. Just to show you, this is the medical thoracoscope that we use. It looks exactly or very similar to a bronchoscope. It's shorter, it's rigid or semi-rigid. The proximal part is rigid and the distal part is flexible. It has the same handle as any other bronchoscope, so it was made for pulmonologists, you can tell. We use the same tools that is used actually in bronchoscopy, the forceps and everything. Laser, if you want to laser, electrocautery, etc. This is a diagram of what a simple adhesion actually could be. You just take them down. Simple adhesions do not involve or do not contain any vessels at all, or lung tissue. Complex adhesions do actually have vessels, and they're difficult, much more difficult to try to take them down. Another option that we have for management of malignant effusions is the placement of indwelling pleural catheters, or IPCs. The indwelling pleural catheters are soft catheters made out of silicone. They're actually a 15.5 French tubes. They can actually be used in malignant effusions that do or don't have trapped lung. And that's one of the advantages of this. Spontaneous pleurodesis can happen, or it's also called autopleurodesis, in these kind of patients who have these catheters. And the reason for that is all the inflammatory response that the catheter itself will create in the pleural membranes will actually lead to formation of adhesions in long-term autopleurodesis or spontaneous pleurodesis. You can see that in an average of 40% of patients after 2 months. This is a picture of an IPC, an indwelling pleural catheter. This is the part that goes out of the patient. This is the part that goes inside of the pleural space. There is a cuff that is actually left in the tunnelized part, and that will create granulation tissue, which in the future will prevent the catheter from being moved or migration. These are the bottles. These are the bottles that are actually used to drain or the IPC catheters. In general, after placement of IPC catheters, the previous studies actually, what they did is patients would be discharged home. They would do it by themselves or somebody else helping them. And that was the whole idea of giving independence to these kind of patients and not to come back with recurrent effusions all the time. They would drain an average of every other day, which is 3 times a week. This is the previous studies. However, I'm going to show you in a minute another study. This is how it looks. The catheter, after you place it, is actually very well sealed. Patients can take showers, etc. So it should not bother the patient a lot. You have to remove the dressing in order to, of course, drain the catheter. these bottles are usually mailed to the patient's house, and the company takes care of that. So it's actually very easy and simple in terms of the management for when you place an IPC catheter. Different studies have been done with IPC catheters in general. Most of them, or almost all of them, have shown symptomatic improvement. And as I said, that's the main goal of management of malignant effusion. One of the issues, though, that could come is, as you can see on the left side, is the complications. And one of the common complications seen, up to 8% in this study, is symptomatic loculation. So because it's a catheter that is literally floating around into the pleural space with the fluid, the autopleurodesis that happens does not happen in a regular fashion. So there are some areas of the pleura that will actually get stuck together, but some areas where there will be loculation of fluid, and the fluid will remain. Sometimes that can become an issue overall if the patient is still symptomatic, and you have now different pockets of pleural fluid everywhere that you probably have to drain. That's definitely a complication, as I said, and it can happen up to 8% of the cases. In 2012, the publication of the TIME2 Trial, they wanted to compare, and this was a randomized trial, to try to compare two types of treatment. One is with IPC catheters, and the versus chest tube pleurodesis as with Talc Slurry. So they randomized these 100 patients with malignant effusion, and the outcome too actually was dyspnea relief. In general, what it showed is, yes, there was an improvement of dyspnea in both groups, but that was not significantly different after 6 weeks or after 3 months. However, at 6 months, there was a slight improvement of the dyspnea in the IPC catheters compared to a chest tube pleurodesis. Another point to take from this study was that IPC catheters actually had a higher rate of complications compared to talc pleurodesis. However, this was not significantly different. In general, what this study proved was that either IPC or talc chest pleurodesis, none of them was superior to the other one. In 2012 at Johns Hopkins, they did this pilot study with 30 patients. What they tried to do, let's say they wanted to combine the Thoracoscopy pleurodesis versus with a placement of an IPC catheter. So they did this in 30 patients. Everybody got a thoracoscopy talc pleurodesis, immediately followed by placement of the IPC catheter in the same procedure. They got admitted to the hospital. They did get a chest tube, a large bore chest tube, for only 1 day, and then the chest tube was removed. Patients went home the next day. So they only stayed in the hospital despite this talc pleurodesis for only a day. And they were draining the catheter, the IPC catheter, 3 times for the first day, then 2 times for 2 days, and then 1 time for the rest of the days. Most of these patients, as you can see in the graph here, is the length of time with the tunnel catheter was only a week. So after a week, patients had achieved pleurodesis, and the IPC catheter was able to be removed. What it did basically show that this procedure is possible, but at the same time it decreased the length of time of patients receiving thoracoscopy pleurodesis, which is usually an average of 4 or 5 days inpatient. Most recently, and this is a few months ago, the release of the ASAP trial. What they tried to do is they randomized patients who had an IPC catheter placement to either have an aggressive drainage, which they consider daily drainage after they were discharged from the hospital, versus every other day drainage, which is how originally they did the study when they placed their first IPC catheters a few years ago. They actually show a higher rate of autopleurodesis in patients with daily drainage group, and also shorter time to autopleurodesis, 54 days. Now, as you see, the numbers here are very similar to the first study done a few years ago with 250 patients, which was actually retrospective. So, in general, you can tell that less than half of the patients with IPC catheters will have pleurodesis, regardless of how you drain it, even daily or every other day. And the average time to achieve that autopleurodesis is approximately 2 months. IPC has also been used in patients with trapped lung. This case series of 11 patients at the University of Pennsylvania actually showed an improvement of the symptoms in more than 90% of the patients, 10 of them. No autopleurodesis achieved. It will never be achieved because there is no apposition of the pleural membranes. Now, there are some complications that we're seeing. One of says that most of them actually had mesothelioma. None of them actually had lung cancer in this case series. Now, what is important really to discuss here is what is the cost effectiveness really of all the interventions that we have already mentioned for malignant effusion. This was actually a very nice study done at St. Louis University. What they did is they did a prediction, an analytical prediction of the costs based on what the Medicare was paying at that time. This is in 2000. Actually, they got the data from 2010. And then they did the assumption in patients that they actually treated, 93 patients that they treated with thoracoscopic pleurodesis. They tried to see if they would have done repeated thoracentesis, so they would have done tunnel pleural catheters or bedside pleurodesis. And they compare it based on the assumptions, and they actually compare the numbers with the survival at 3 months and the survivals at 12 months. And you can see here, look at the cost of repeated thoracentesis in patients with a survival of 3 months. $4,000 or almost $5,000. And the second most more expensive was the tunnel pleural catheter. But look at the thoracoscopic pleurodesis. The cost is very, very high when it comes to cost effectiveness. So what happens when you actually see the cost of 12-month survival? Bedside pleurodesis, which is chest tube pleurodesis, actually has a better cost, which is very similar to tunnel pleural catheters or IPC, compared to even repeated thoracentesis. So, for conclusion here is, when it comes to cost effectiveness, which is, I think, is very important to mention all the time, you're trying to relieve dyspnea here. So is it effective, is your intervention effective to relieve dyspnea and for the patient to continue to have that degree of quality of life at a cost that actually takes for that intervention? In patients who are actually, who will survive up to 3 months, it will make sense to do repeated thoracentesis because it's actually less costly. However, you also have to consider that none of these patients will achieve sclerosis, pleural sclerosis, or pleurodesis. However, the most, I would say, the less costly procedure that will achieve pleurodesis in up to 40% is actually the placement of tunnel catheters. This is in 3-month survival. In 12-month survival, probably going with a bedside pleurodesis or chest tube pleurodesis or the placement of a Pleurodesis catheter actually would be very similar when it comes to costs compared to thoracentesis.
And this is cost per patient?
Yes, per patient. So in conclusion, we can conclude that lung and breast cancer are the most common causes of malignant effusion. Remember that the Karnofsky score is very important when it comes to malignant effusion, and in general, all malignant effusions have poor prognosis. Asymptomatic patients with malignant effusions probably is good just to observe. Remember, the goal of management in these patients is just to relieve dyspnea. Pleurodesis can only or should only be attempted when there is almost complete apposition or re-expansion of the lung. Otherwise, it will have a low effectiveness. Trapped lung, in general, is the ideal therapy for trapped lung is probably placement of intrapleural catheter, probably the only option that you have at that moment. Thoracoscopy could be medical, surgical, either way. And the factors to consider before management, very important, is what's going to be the survival of the patient. How long do you think the patient is going to do? That should actually drive the type of technique or therapy that you're going to offer the patient. Is there going to be a symptom relief, meaning dyspnea? And is it really cost effective for this patient?